I think we're all set. If you want to go ahead, Dr. Castellan.
Okay, good afternoon, everyone. Thursday, November 19th. This is the Protocols, Medications, and Devices Standing Committee. I'm Franco Castromarin, the chair, and we'll go ahead and call the meeting to order. Shelley, can we start the roll call, please?
All right. Amber Rice.
Present.
Brian Smith.
Brian present.
Come to the monitor, Brian. Is he there?
He's logging in as well.
Okay, thank you. Chester Key.
Present.
Franco Castromarin.
Present.
Garth Gamer.
Present.
Heather Miller.
Hi, Shelley. Can you hear me? I'm here.
Hi, Heather. Thank you.
Thank you.
Jason Johnson.
Here.
Jason Payne.
I'm here.
All right. Josh Gaither.
Here.
Matt Shaw.
Here.
Neil Gago. Neil, are you on the call? Paul Dabrowski. And Sherry Brand.
Here.
Count 11. We do have quorum.
Okay, thank you very much, Shelley. We're going to start off with some housekeeping and announcements. The first issue is that if you're joining us by video conference, if you hover your mouse over the bottom part of the screen, the buttons to turn on and off your video as well as on and off your microphone are located there. Attendees are advised that this is a public meeting. We are being recorded, and recordings are posted to the Arizona Department of Health Services website. So anything said verbally, anything viewed via webcam, or anything typed in the chat box will become part of the recording that is posted for public consumption. Please mute your microphones when you are not speaking. Please remember not to put us on hold. If you're attending by phone only, press *6 to unmute yourself. Shelley will be displaying materials for the group, so there's no need to present your screen or share your screen. Shelley and Julia will monitor the chat box for questions. For everyone's benefit, please identify yourself before stating your remarks. We'll go ahead and start with my chairman's report. Attachment 3A in your handouts is the attendance report for your review. Friendly reminder that if you miss 2 consecutive meetings, the Bureau will contact you to ask you if you're still interested in serving on the committee. The second part of the report is the vacancy report. We have no new members to announce. If roster updates are approved later in the meeting, we will have 1 vacancy for a toxicologist, and that will be discussed in more detail shortly. Bureau report, please.
Good morning, this is Julia with the EMS for Children report. The biggest thing for the National EMS for Children program is that national data collection among EMS agencies is starting again in January. So this is the same survey that went out earlier in the year. We also just got our Safe Sleep module approved this morning at the Education Committee meeting, so that should be available on the ADHS website soon.
Thank you very much for that, Julia. Can we get a report on the opioid and cardiac arrest data?
Yeah, Julia, I'm going to present something real quick. We know during the pandemic period, some of these statistics have been of interest to everyone. Opioid use, the rate of opioid use from March through September has increased pretty substantially for a variety of reasons. That is something the department is continuing to kind of track and monitor, and we will continue to make some of the statistics available. And I should say it relies upon agencies reporting, so we certainly appreciate that agencies continue to report suspected opioid cases, as well as cardiac arrest. So we know this is particularly of interest. This chart only goes through July, when there was the very substantial spike in cases, but the cardiac arrest rate increased very dramatically, through the late spring and summer in July, and it's still above the previous 2 years, but has gone back down from where we were in July, as well as the proportion of pronouncements on the scene. So patient disposition through July for dead on scene dramatically increased, and transports for cardiac arrests decreased. So that is something else we keep a fairly close eye on, and we'll continue to present these results as we get them, probably through the end of the year at the next meetings. And that is the opioid and cardiac arrest update.
Thank you very much. All right, so next item on the agenda is the regulatory and bureau chief update.
All right, can you guys hear me okay?
Yes.
Yes,
Excellent.
go ahead.
Okay. Thank you. We had some audio issues the last meeting, so I just wanted to confirm. So I wanted to have a welcome for Rachel Garcia, who is our new bureau chief. After Terry left us recently, we've had a search that's gone on over the last couple months, and this is Rachel's first week with the bureau, just in time for all of our standing committee meetings. So we are excited to welcome her and bring her on board, and I will hand it over to her for her introduction.
All right. Good afternoon. Well, thank you very much for having me. My name is Rachel. I've been with Department of Health Services since the Deputy Bureau Chief, working in Public Health Emergency Preparedness. And for the last 10 months, I have been supporting the COVID-19 HEOC response here at the department. So I want to thank you, and thank you for your patience as I transition into this Bureau Chief role and continue to provide support to the response here at the department. I will quickly provide a briefing on our current response activities, and then I'll turn it back to Dr. Gale for some additional updates. As of today, we are at just over 287,000 confirmed cases of COVID-19. There are currently 2 key benchmarks that we are tracking that are suggesting substantial spread statewide, although we are observing differences by region throughout the state. Today, hospitals are reporting ICU and med-surg bed capacity at 89%. Our HEOC and our surge line are in communications with hospitals, and we are keeping a close eye on facilities that are reporting staffing issues currently. We're looking forward to Thanksgiving, and ADHS has provided recommendations on how to have a safe Thanksgiving. Yesterday, Governor Ducey and Dr. Kara Christ provided a press conference and made announcements about additional support for testing at airports, masking at schools, as well as additional staffing support that will be available to hospitals. There was also an executive order issued yesterday, which is an enhanced surveillance advisory on immunization reporting, and it details reporting requirements for providers that will participate in the COVID-19 vaccination program. Along with that, we expect that there will be an update and renewal to the EMS waivers that are currently in place. We'll make sure that we keep all of our partners updated on this information. We are getting additional information that there may be a vaccine available, possibly 2 presentations available under an FDA emergency use authorization by the end of the year. Exciting news, and we're working really hard to make sure that we are prepared and working with our local partners to roll out vaccination in Arizona. I look forward to participating in future committee meetings, and I will turn it over to Dr. Gale again. Thank you.
Thank you, Rachel. Welcome. Just a reminder that the rule writing process is ongoing. I think the most interest has been with Article 9. Those meetings are announced publicly. We do make sure that that gets shared as widely as possible. So if you are signed up for the Bureau's Gov Delivery, listserv. You should get the meeting announcements via that method. We also make sure to send it to the regional councils to go out, and as many other options to make sure that it's very publicly available to everyone. We got some great feedback from the Education Committee regarding some ongoing requests for the rule waivers that are in place. As Rachel mentioned, we anticipate that these will be updated within the next week. But again, if you have any feedback or ongoing needs to make sure that you can respond as an EMS provider or agency in Arizona, please keep us posted. And that's all for us. Thank you, Franco.
All right, moving on to action items. The first item is going to be to review and approve the PMD minutes from July 16, 2020, attachment 5A.
So moved. It's Brian. I am here. Apologies.
Thank you, Brian. Can I get a second?
Second, this is Garth Gamer.
Dr. Gamer for a second. Any discussion? All right, call for a vote. All those in favor to approve the minutes, say aye.
Aye. Aye.
Aye.
Any opposed, say nay. Any abstentions? All right, the motion carries and the minutes are approved. Thank you. And the next item on the agenda is to review and approve the Table 5.1 Arizona Scope of Practice Skills. Can I get a motion to approve?
So moved, Matt.
Any second?
Second, Garth Gamer.
And open for discussion. I'll start the discussion by just pointing out, Shelley, that the area highlighted in blue refers to the PDF for the rules, page 102. I believe that's a typo. I was reviewing that last night, and I believe the area it should refer to page 101.
All right.
That's the page that contains the information referenced by the highlight there.
Okay. Noted that I made that error.
Any other comments or discussion?
So Franco, this is Gail. I can give a little bit of background of kind of why this came back to this committee. So at the last PMD committee meeting, this group had approved some updates to the scope of practice that went to EMS Council and MDC. After the PMD meeting, Brian had identified some potentially issues within our recommended updates as they pertain to rule. And so the recommendation was made at EMS Council to approve the majority of them, but to review a few specific line items, and then also to remove essentially the entire what was termed medical director approved medications, which was one of the sections from the national scope of practice. So Brian very kindly met with Shelley and myself after the EMS Council meeting, and we went through all those changes and want to bring that back to this group to review again. Again, we wanted to make sure we didn't create a scenario where we potentially put a recommendation for a scope of practice update that was in conflict with rule. So that is the background with some of these changes and why we're asking PMD to review the specific highlighted areas again.
All right, is there anything that needs specific walkthrough, you think?
I think on the first page, if you can just quickly show the highlights, one of the issues that was identified was Cpap. We had recommended this be a check mark. The concern is that not all EMTs have medical direction within the state of Arizona. And so that would be somewhat problematic in that we could potentially be approving Cpap for EMTs that do not have medical directors to approve this for them. So the recommendation would be that that is a STR, which means only EMTs who have medical directors who approve that skill could perform it. The other piece was also under Untitled CO2 Monitoring, just to match the national scope. This would be a STR as well. If you can scroll down to the next highlighted section, please, Shelley. This section, there was a couple recommended updates. So the national scope of practice very specifically lists immunizations. And so we wanted to kind of delineate that from intramuscular. One of the reasons that you see the little syringe symbol next to EMTI and paramedic, as Brian had pointed out, there is R925-505, which are the specific requirements for EMTIs and paramedics to administer immunizations within the state of Arizona. The national scope does allow this at AEMT level. This was removed because, unfortunately, in R925505, AEMTs are not specified. So if we added this check mark in the AEMT section, it would be in conflict with rule. So that's why we recommended taking that out and then just adding the reference to indicate for EMTIs and paramedics that they would need to follow R925505. The other piece, we kind of specified the intranasal. We had this piece before. We had the additional line that specified pre-measured dose, and this was really added for naloxone administration. The thought in simplifying this is to recommendation for this group to consider that really if an EMT is giving intranasal naloxone, they're typically going to have a pre-measured dose, but some entities do use the naloxone that they have to actually draw up and measure. And so we wanted to just allow that as an option to ensure that we have an adequate response to the opioid epidemic. Any questions or concerns about those changes?
Yeah, Dr. Bradley, this is Dr. Marin. So with deletion of the intranasal pre-measured line and just keeping it to a general intranasal language, what is the net result of that then?
That essentially would allow agencies that are unable to afford or purchase the pre-made kind of commercial versions of the intranasal Narcan, they could purchase at a much lower cost the kind of essentially IV form of Narcan and just attach the mucosal atomizer device to it. So they would essentially not have a pre-measured at 0.4. They could potentially give up to 2 milligrams if that was a dose in the IV formulated. If that makes more sense.
Yeah, and so, but the way it shows is that it would be approved for EMTs even without medical direction to draw up the drug at the correct dose and administer.
So EMTs are allowed to administer naloxone per executive order that was passed several years ago. That was why we created the online training that through the education committee. So all of that training was kind of covered as part of the governor's executive order from several years ago.
And that was also a statutory provision. There was a statute passed specifically authorizing EMTs and law enforcement, and it basically gave any physician or nurse practitioner the ability to write a prescription and a standing order for them to do it.
Excellent, thank you.
And also in the state of Arizona, if any EMT does not have a medical director, they are able to use a standing prescription that is signed by me as the state EMS medical director for specific to naloxone. So that a standing order is in place as well. Any further questions or concerns about that piece?
Are there any other highlights below? Further down?
I think just the very last page, the only other, we just essentially moved this to this section was to add thrombolytics. There really wasn't a good place for this before, and so we added it. It's not really Arizona specific, but in Arizona, we consider thrombolytics to be a STR, and so we did not change the type of administration of who could give it, but really just where the area fell to make it Arizona specific.
All right, any further discussion or questions for Dr. Bradley or the Bureau on this matter? All right, hearing none, we'll go ahead and call for the vote. All those in favor of approving the new this new draft of Table 5.1 with the aforementioned and summarized changes from EMS Council, all those in favor, please say aye.
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 Any opposed? Any abstentions? Okay, the motion carries. Thank you, Brian, very much for your extra time with Dr. Bradley and the Bureau to iron out those conflicts and avoiding future problems. We really appreciate your time and effort and your deep knowledge and institutional memory of these matters. So very, very much appreciated.
You're welcome.
Okay, so the next item is to discuss, amend, and approve the bylaws and updated roster rules. This is attachment 5C.
There was one on that first page there. It was a last minute change from 13 members to 14 members. It doesn't look real pretty, but that's what that was.
Okay. All right, can I have a motion to approve?
So moved, Dr. Gamer.
Second, Amber.
Okay, open for discussion. The biggest change here again is the addition of a toxicologist, as you see there on the final page, the page currently on the screen, which will take us to 14 members. And that, of course, changes the quorum requirements. I believe, Shelley, you said it changes the quorum to 8.
That's correct.
Okay. Any other comments, concerns?
This is Gail. I thank the committee for considering this. We found that as this committee makes recommendations to MDC, we've had multiple issues that we've actually consulted a toxicologist to help with a lot of the work that PMD puts out. And we thought this would be a nice benefit to have them as a regular component of our committee. The one issue that just wanted to make sure the group is aware is that makes this an even number. So if there is ever a situation where we have an even number, that could potentially be problematic on a vote if we had a 7-7 split. Typically, I think this group usually unanimously approves things, but just wanted to point out that would be the only potential issue with having a 14 member committee, but I think the benefits probably outweigh that, but just wanted to make sure the group was aware.
Is there a process to break a tie that's currently in statute or rule somewhere, or no?
It's Robert's Rules of Orders. So the chair doesn't usually vote.
Correct.
So they could potentially, if that person doesn't vote, then in this case, there's 13. It would be difficult to have probably really a tie anyway.
Yeah, fair enough. Thanks.
I think that's the way, if my brain is mathematizing right now.
Yeah, Brian, Dave, I think you're correct on that point. Similar to how the Senate handles with the vice president point on a tie.
Franco, you have been promoted. You are the equivalent to the vice president and can break a tie.
That's awesome. If anybody sees any flies in my hair, please let me know. I'm on camera.
Dr. Moritz, Josh Gaither. Can I ask a question with, and please take this as a pure question and possible suggestion. If this causes problems, I'm happy to not do it. There are 2 toxicology groups in our state. On some issues, we have had significant differences in opinions between the 2 toxicology groups. This is applied, I think, with snake bites in the past, as well as, I believe, one of the issues was charcoal and whether to give it. Would this be an area where we would want to, just like we do include a representative from each region, include a toxicologist from each poison control center? That would solve the uneven numbers. I don't know if that's possible or desirable.
So I think, yeah, I think my vote would be to probably just have one, only because I think if we start to get too many toxicologists, we may get kind of a deviation from really the EMS related issues. So that would be my thought, would be to really focus on one, and certainly understand that the recommendation from PMD is ultimately up to MDC to make a final decision. So MDC always does have that final vote on whether or not things move forward in Arizona. So that would just be one consideration. I feel like we could potentially have both groups with varying opinions covered, but for the overall EMS community across Arizona to get to make the final decision, if that makes sense.
And also to dovetail off of what Dr. Bradley just said, much like we have a single representative for regions of care, perhaps whoever is ultimately selected as the representative toxicologist, part of their charter or their understanding of what their role is to try to find try to find agreement with their recommendations internally before essentially trying to find their own consensus internally before bringing it forward to this committee and looking at their role in a more broad subspecialty based rather than group based opinion, if at all possible. Any other comments? All right, then we'll go ahead and call for the vote. All those in favor of approving these new roster and bylaws, please say aye.
Aye.
Aye. Aye.
Any opposed, please say nay. Any abstentions? Okay, and the motion carries. Okay, so the next item for discussion will be to discuss, amend, and approve Table 1 titled Drug Box. And this is attachment 5D and E. And it looks like a couple of, one major issue was the addition of inhaled anticholinergics to the EMT level. And then the next one was additions of over-the-counter analgesics for pain and fever to all levels of care. And these are both found in the same document. Can I have a motion to approve?
So moved, Gamer.
Second,
Any
Amber.
second? Thanks, Amber. Open for discussion.
Hey, it's Amber. I have a question. With the optional over-the-counter pain relievers, there's no specifics, obviously, with that. So that would include anything the medical director would approve, or would we need to be more specific with this line?
Sorry, just to clarify, so we make sure we match the agenda, we do need 2 separate action items. So we can address either first, but we just need to specify which the action item is because there are 2 different items on the agenda.
Thanks, Dr. Bradley. So just in keeping with Amber's question, then let's discuss first the over-the-counter analgesic pain reliever to all levels. So this is a question I had as well, whether or not this is going to get more specific to just anti-inflammatories and acetaminophen, or if we're going to keep it non-specific.
It's Josh Gaither. I'll share my personal opinion. I like this being general because there are so many different formulations. It would be very, very difficult to be specific.
And this is Gail. This verbiage we took specifically from the national scope. The only difference, actually, there is no difference. I apologize. The 4 columns, they include EMRs not listed, but we have EMTI, so that's why we have 4 columns. But the national scope uses this exact verbiage to make it more generalized just due to the large numbers, and they include EMT through paramedic level.
Thank you, Gail. I definitely would be supportive of adding this into the drug box list.
Any other questions or comments? All right.
Dr. Gaither, Dr. Gaither, this is Noreen real quick. I believe on one of the medications that you added, just keep in mind, anything that you put on the BLS level, if you don't put optional next to it, it will require them to carry it on the ambulance. It will conflict with a rule that we have in Article 10. And I think there was something early on that you guys went over quickly. Was the, I want to say, an inhaled agent? Like I said, I'm multitasking, so I didn't, but I quickly saw that it's not listed as optional. It's in.
Actually, we're just on the over-the-counter one right now because they're two different action items, Noreen. So
Oh,
we're
okay.
going to do.
I'll be
We went a
quiet.
little out of order. Sorry on the agenda.
All right,
That's
I'll be
my
quiet
apology.
then.
That's my oversight. And so just to summarize, Noreen, anything that's listed as an A designation on the right-hand side on BLS will require them to carry the medication unless it's listed as an option. So the over-the-counter analgesics currently are listed as A, but they're also listed as optional. So my understanding then is that go ahead.
That would be fine. I saw something added on above that, and I just want to make you aware of that. And we've talked about this before. It's kind of a rule in Article 10 that requires BLS to have everything that's on this list if they're authorized to use it, unless it's optional.
Understood. All right. Any other comments at this time? Okay, well, let's go ahead and call for a vote. All those in favor of adding specifically over-the-counter analgesics for pain or fever as an optional medication for all levels, please say aye.
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 Any opposed? Any abstentions? All right, and the motion carries. Thank you. And then we'll go back one item, which is to consider inhaled anticholinergics to the EMT level. And so this is ipratropium listed as 5 ml vial, and it's listed as an A across all levels. So in its current iteration, it would be considered mandatory for BLS crews as well. Open for discussion.
Franco, I think this needs a separate motion to discuss.
Okay, thank you. Can I have a motion to approve?
So moved with the designation of optional, and I believe that it's being added for EMTs and AEMTs as well. It's already present for I's and P's.
Can I have a second?
And Brian will second that, but we're going to have an exception in the option also, which I'll talk about after.
So open for discussion. So far, I hear that we will add the designation optional to what's shown on the document currently.
But it needs to say optional for EMT and AEMT. We should not make that optional across the board, I don't think.
I'll change my motion to that effect.
Any other comments or suggestions? Is there another precedent for medications that we list as partially optional for certain skill levels? Anywhere on this table?
I think, isn't it under naloxone? Well, we have 2 naloxones, and we did that because we wanted the 3 levels carrying it who it's in their scope of practice, and then we did the next line down. So we could do it in a different line. I just don't know whether we need to.
We also have that for aspirin as well. So we do have the precedent of a few medications where we have it optional, only listed for EMT, and then as a required agent for AMT and above. So if you scroll up to the aspirin, you can see that format may work nicely for this as well. And we actually have it for albuterol too. So if we match the format for albuterol, that would essentially match that for the ipratropium.
Excellent. All right, so we will make that amendment that we will make this medication optional for EMTs and was it EMTIs? Is that right?
AMT.
AMT, and then we'll keep it mandatory for EMTI and paramedic.
So are we looking at putting a secondary line for that, for the optional, for the EMT, AEMT? For the ipratropium? Like the albuterol and the aspirin?
Yeah, it sounds like the suggestion is to use the precedent that we used for at least albuterol. Seems like it would be the most straightforward.
Albuterol and aspirin looks like it's already that way. So we just, if we did, like you said, follow the same suit for the ipratropium.
And I'm very happy with amending my main motion to that effect as well.
Any other discussion? All right, we will call for a vote. All those in favor of adding the ipratropium bromide with the amendments of changing it to an optional agent for EMT and AEMT only, please say aye.
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 All those opposed say nay. And any abstentions? Okay, and the motion carries. Thank you. So that should cover items 5D and 5E. Are there any other items to be brought forward for the next meeting, to be considered for the next meeting? Any calls to the public? Okay, for upcoming events, please visit the Bureau's news and conference pages for upcoming events and as well as upcoming CE opportunities. Our next meeting will be March 18th, 2021 at 1200 hours, location to be determined. And if there's nothing further, then we will call to adjourn.
Chair, this is David with the Bureau. I'd recommend also that attendees and members check the Education Committee for website for additional CE opportunities, as well as the one you just mentioned for news and conferences.
Thank you. Thank you for that reminder. And it looks like before we adjourn, I did not see that upcoming event, but it looks like March 1st and March 2nd will be the NAEMS Annual Pediatric Symposium up in Flagstaff. And in addition, I'll just add that the National Association of EMS Physicians Scientific Assembly will be occurring in, I believe, the second week of January, if I'm not mistaken. And that will be a remote experience online. So that's another one that we can add to the agenda as well. Any other comments before we adjourn? Okay. Thank you very much, everyone.